Welcome everybody. I'm a consultant in public health based in Kent County Council. I'm actually a medic by background, so I'm not an analyst. Neither have I got a PhD or anything in this space. I got involved in this simply because I have one of my in terms of my portfolio of work that I do in local authority public health is that I take on a strategic leadership role for data and analytics for our team in public health in the county council, but also I work very closely with the NHS around analytics, providing support for the broader system. And many years ago, I bumped into Peter Lacey, who's our external consultancy partner for this work, and he will introduce and explain his role specifically. And I bumped into him many years ago to actually answer a very wicked issue about how we can actually develop analytics that actually support very, very complex decision making and particularly around systems planning or health services planning. So without much further ado, so the work that we've been doing in Kent has been in collaboration with Peter's team called Whole Systems Partnership, and it was based on a special request that was requested by the Kent Health and Wellbeing Board. At that time, we had health and wellbeing boards across different localities in England, and it was back in 2017. So as many of you are aware, as per the Health and Social Care Act, there is a statutory requirement for both local authorities and the coterminous health NHS commissioning bodies, which are now called integrated care boards, to come out with a JSNA or a joint strategic needs assessment. A lot of the JSNAs that you'll see are online, and they usually look at basically a compendium of information on health inequality, surveillance, indicators of health, population health and well-being, which is basically looking back in time around whether health inequalities have improved or worsened. But actually, very few JSNAs actually then look forward in terms of how those trends change over time, and more importantly, how would they improve if we were to invest in prevention services at pace and scale? So this was the wicked issue that was facing us in Kent for many years, and we then attempted to address this by creating a very unique tool called the JSNA Cohort model, which is entirely based on a well-established modeling approach called systems dynamics, which I'll explain very shortly. So as I said, it's basically there to provide an evidence base to support our joint health and well-being strategy. Now, as you may be aware, we normally call it as the IC strategy or integrated care strategy as termed by NHS England. It's also to satisfy and enhance our local JSNA capability with prospective modeling able to simulate what-if questions, to describe scenarios, describing complex strategies that combine different interventions. So the problem with modeling is that if you're only modeling the effect of one intervention, it doesn't really give you the full answer, because in a complex system, we have multiple interventions all happening at the same time. So what is the JSNA Cohort model? It's a stock and flow modeling tool based on system dynamics to estimate the changes in population segments over gender, based on gender, age, and cohorts, taking into consideration underlying demographic differences, underlying risk factor changes, and risk factor scenarios. We use SD when the scope of issues that we're trying to model or explore are strategic, population, or cohort level. It's not for tracking specific individuals within a system. It's also when we want to exert controls over the system through basically on rates, particularly like prevalence of long-term conditions, prevalence and incidence of long-term condition, rates of hospital admissions, things like that. And we use SD mainly when the time scales, when we're modeling, we want to look at, say, in the next 5 to 10 years or 20 years, rather than, say, in the next day or so. And this is vastly a very essential tool nowadays to help in terms of policy making and policy simulation. So if we want to implement a new policy around integrated care, the use of dynamic modeling to really understand real numerical changes in our population really helps in that regard. So how does it work? It's basically think of a bathtub, which is based on the conceptual diagram shown on the top right-hand corner, where you have You have water coming in into the bathtub and then water going out. So you apply that in terms of a population context. You have incidence of a long-term condition causing prevalence, or the number of people at a defined time having a particular long-term condition, and then those people either being treated or getting worse or dying from it. So it's essentially these kind of particular aspects of modeling, which involves stocks, which are point counts, and then you got flows, which are the incidents, and then you got dynamic events like factors changing incidence, changes in treatment, or system delays, basically around time to treatment, disease progression, etc. And the diagram on the bottom right-hand side is what you would see, a proper system dynamic model where you have a stock and a flow and those valves, which are basically controlling the flows. So what did we do in the JSNA Cohort model? So in our JSNA Cohort model, we've actually used some key design principles, basically looking at prevalence age rates across different by gender and by different age groups, or basically, so I believe that's 5-year bands, I think it was. So, and then we looked at the prevalence of long-term conditions ranging from no conditions versus population groups having a single long-term condition versus populations having multiple long-term conditions, and then frailty. So we added, we assembled all of that up, and it became quite a complex piece of work, system dynamic model, as likened to an enormous wiring diagram, which Peter is, I'm sure Peter would be happy to share with you offline if you want to see the enormity of the and the complexity of the model itself. So essentially, the core design principles are basically around which is around the flow aspects. So what we've done, what Peter and his team have done, is created an aging chain, which is based on 5-year aging chains, and applying the incidence and prevalence of long-term conditions based on those different age groups. I have to say that you can't really do this without a linked data set, and the fact that we developed this. We started developing this years back was actually aligned to our development of our locally linked dataset known as the KIT, or Kent Integrated Dataset, which was particularly instrumental in helping us pull this together. But that being said, Peter and his team didn't really use just only the KIT. They used lots of other sources of data, like big survey data, like I think ELSA was one of them, for example. And then, so you've got the incidence incidence of long-term condition, and then you've got particular risk factors, which are shown on the in the middle sort of bar there, ranging from current smoking prevalence, blood pressure, cholesterol, and various other things, and they're also applied. And then you actually then get levels of different populations experiencing these different events and factors. So the JSNA Cohort model uses the same segmentation approach underpinning population health management approaches, but is designed to provide a prospective answer to a series of what-if questions informed by local and national evidence of impact. The model has been developed with the potential to be calibrated and used at a system, place, and neighborhood levels, with recent applications focused on place and neighborhood to ensure sensitivity to local socioeconomic demographics characteristics. The model reflects health behaviors accounting for 30% of what affects our health and well-being, and explores the impact of modifying these. It's also about developing its approach to modeling the impact of socioeconomic factors, which accounts for about 40% of our, well, actually, I don't think it's so 40%, it's more like 80%, if I'm not mistaken. Using the, and then using the above to inform not only the health outcomes, but also the access rates to key health and care services. So in terms of the cohort model, it starts off with a section on the children side of things, and about 10% of children experiencing 4 or more ACEs, or adverse childhood experience. We actually call it trauma, I think, nowadays. Yeah. They have a significant impact upon population health and mortality. So, for example, a child with 4 or more ACEs has 3 times more likely respiratory condition as a child and an adult, 2 times more likely to have a cardiovascular disease condition or stroke, or 1.5 times more likely to have diabetes. So in that regard, when we initialize the model from, say, 2023 onwards, if ACEs are avoided for all newborn children, this could add, say, 0.6 to 0.1 years of average whole population healthy life expectancy and years of period of life expectancy at birth, respectively. And it then reduces by about 12,000 to 900 the number of people with asthma or a severe mental illness, respectively, across Kent. So the prevention strategies, these are all about managing risk at all stages of need. Shorter term projections for different cohorts of need can help in keeping people healthy for longer, as well as target differences, types of care needs. Base cohort projections estimate between 2022 to 2027, and these are the number with no long-term conditions or frailty that will increase about 3%. Single long-term conditions will increase about 3%, and multiple and complex conditions would increase about 16%. Frailty will also increase by about 16%. So all of these kind of projections illustrate how much of the changing levels of health need as opposed to looking at flat population level changes. So when we look at people with multiple or complex needs, even though the prevalence of some long-term conditions are decreasing, the aging population means that the number of multiple and complex conditions is likely to continue increasing. Model estimates show that there's a 34% increase in multiple and complex conditions over the next 20 years. And that would mean, so 33% from multiple complex conditions, multiple conditions, and 40% increase in complex conditions. So what do we mean by multiple conditions? So that's 2 or more long-term conditions. And then complex is when we are referring to dementia, serious mental illness, or neurological conditions and learning disabilities. So when we put all of this together, we're also having then looking at the level of risk factors. They're also changing over time. And as we all are aware that smoking prevalence is actually reducing quite a bit. If you look at the diagram below, you'll see that actually from 1999, over the last between 1999 to 2014, we've seen smoking prevalence, physical inactivity, blood pressure, blood pressure. They're all actually reducing in terms of incidence. And I think, if I'm not mistaken, there is a slight increase in BMI. Well, actually, that is probably true because of the rising levels of obesity. So the scenario planning here is, what if we were able to reduce the levels of smoking, say, to about 12% across Kent? And then when we adjust the sliders and buttons in the model, and we hit run, we're starting to see some reductions in long-term condition prevalence. For example, lung cancer reduces by about 620 fewer cases a year, COPD 832 cases, et cetera, et cetera. And then when we want to look at, say, how does that impact in terms of activity, hospital activity? So, for example, we're able to see that the bar charts, that's the blue, red, and green ones, which are basically about the prevalence and lifestyle trends. They're all increasing if we did nothing. So if you look at the blue bars, their bars are actually just showing if we didn't apply those prevention interventions. Whereas what we're seeing in terms of the red and green bars is actually we start to see the rate of increase in terms of A&E attendances, and will actually the rate of increase is actually being slowed. So if we did nothing, it will be an increase of about 40% in terms of the burden of ill health. Whereas actually, if we actually started to implement prevention changes, the rate of increase would probably go down to about 7%. And that's when we're including, say, prevention interventions for lifestyle as well as for, say, hypertension management. So it's that kind of outputs that we're trying to generate from the model. And this is really particularly helpful in terms of then putting into health needs assessments, which all then form our statutory requirement for JSNA. So how has the JSNA Cohort model been used? Before COVID, the model helped inform the Kent-wide local system JSNA work. I don't know if people will remember the 5-year long-term plan submission that we had to submit before COVID. Just before COVID, that really helped in terms of our long-term plan submission in Kent and Medway, and we were able to generate estimates for mental health, multimorbidity, and frailty, and then the impacts in terms of how would they all change if we were to invest in prevention. And then during COVID, we did a lot of work in terms of applying, well, not us particularly, but Peter's team supported by us, applying the JSNA cohort model outputs to actually then create a customized model to actually help in emergency planning for particularly hospital planning for COVID response. So if anybody wants to read all of the detail behind it, it's all available in the published articles that we recently published last year. One is on the JSNA cohort model itself, another one specifically on the COVID modeling. Just to let you know, I've emailed the presentation to Rachel so she can circulate it to the rest of the group if anybody's interested. So I'm going to hand it over to Peter now to talk about specifically how we're starting to use the JSNA cohort model as of now, and particularly around some of the work that we're doing in public health. We're going through a major transformation program and reviewing all of our commission services. And just for those who are not fully aware, local authority public health commissions a range of health improvement services like stop smoking, stop drinking, and so on and so forth. We're actively using the cohort model to actually understand, to do some scenario testing, to actually understand how it can support some of our planning and decision making. Over to you, Peter.
Thank you very much. Rachel, we're about halfway through sort of thinking and managing time, and that's a chunk in terms of just the conceptual baseline of the JSNA cohort model. It might be worth just seeing if there's any questions or clarification on that before I then go on in terms of current application. So if I pause for 20-30 seconds, if that's okay, there may be either a hand or a comment in the chat.
So does anybody have any sort of comments they'd like to share so far? Any questions? I know Andy's been putting a couple of helpful links in the chat to support what's been said. There's no comments on Menti. Well, there is one. There's one about a little bit more information about your integrated data set, but that's probably for another day. Yeah. That's a whole new session. So no, I think we're good to go, Peter.
Okay, that's fine. So Abraham, if you stay in control, and I'll sure. Comment to each. So yeah, so I'm Peter Lacey. I fell into system dynamics modelling in the early 90s. Goodness me, what a long time ago, when there were such things as regional health authorities, which bear a striking resemblance to integrated care systems and boards, I suppose, at the moment, in terms of their geography and some of their responsibilities. And I'm not an analyst by background. I think there's an interesting sort of overlapping Venn diagram of modelers and analysts, and some modelers sit in a box with minimal analytical capability and skills. Some analysts sit in a box with minimal or limited modeling capability and skills. Obviously, there's a perfect sort of sweet spot in the middle. But I suppose I define myself as a data geek with a systems thinking brain, and that's lent myself to this type of modelling, and also seeking to answer questions of a strategic nature across health and care for 3 decades. So hence system dynamics being a tool of choice very often. So JSNA cohort model, it's there, it's in the system. We are constantly seeking to share and develop the capability within local teams. The public health intelligence team now has 3 people at least who are moderately competent, certainly understand how to go under the bonnet, can manipulate a large model like this, but also can do, I suspect, some of the types of things that you are describing in terms of exploratory models, relatively focused models. So the skills are being transferred, not wholly dependent on us. But we've done 2 things that I'd like to highlight. One is very much conceptual and theoretical because it's a key question, and we've done a sort of proof of concept piece of work, but not fully embedded it within the cohort model. And then I'll come back to the transformation program. So next slide. On the right-hand side here is the sort of conceptualization of how we are intervening within the current cohort model that Abraham's walked through in terms of behaviours that impact on risk factors, which in turn impact on incidence, etc., etc. So that's the sort of from there, the risk factors moving to the right in terms of health outcomes. And there is a degree to which one can explore inequalities on that basis. because risk factors may be more or less prevalent within certain populations or geographies. So there is a contribution to inequality thinking and modelling that can be made within the existing cohort model infrastructure and the likes. However, we know that the wider determinants are not are different from the behaviours that we exhibit. There may be a link, but there are differences. So what we did was that we sought to unwrap the index of multiple deprivation into some of the different elements, and I think we focused particularly on housing as a risk factor. And so you'll see where I'm going in terms of risk factors for certain conditions. Housing may have a risk factor, for example, on respiratory conditions, and things like economic inactivity, perhaps on mental health conditions. And we started to map what was possible, and also then use the actual IMD within different local authority districts within Kent, and did some comparisons, which we'll see in a moment in terms of some theoretical outputs. The next slide compares, and we chose the two areas here. Does it say? So this was the most and the least. So we've got places like Thanet, which are more challenged in terms of deprivation compared to places like Sevenoaks, and sorry, not Sevenoaks, that's in London, but Tunbridge Wells and the likes within the Kent area. And we basically started to look at the relative contribution. You'll see here some outputs over a couple of decades, healthy life expectancy, in terms of changing the shape of those social inequalities from a wider determinants perspective. You'll see the changes are, this is sort of still theoretical, the changes in the bottom right-hand corner are rather sort of one-off. One would expect that to be sort of transitioned and a smoother increase, but it gives an indication in a number of instances and examples that Abraham's also showed. We're asking the question here, what is the contribution to healthy life expectancy of some of those social inequalities? So you can see there's a difference, and there's therefore a basic rationale and a way into the cohort model, or using the cohort of model, a way into asking some of the questions about wider determinants and their impact. The next slide shows some of the data for Thanet versus Tunbridge. You'll see that we've in effect, on the left-hand side, we've got an output in terms of the deprivation quintiles, population in each. And what we've done in the model is shifted, it's very theoretical, but we've shifted everybody out of the lowest quintile because the gradient of additional risk factors is significant between the lower and the mid-range, and seen where there is a potential impact. 12% reduction in inequality there in the bottom. You've got period life expectancy, period healthy life expectancy. So just starting to explore what those mean in terms of wider determinants. It's a question that we're asked a lot. It's not fully embedded within the model, but it gives us a sandpit to play in. The next slide. This takes us on to the transformation program. Abraham has introduced it briefly. There's a sort of a year or two's process being undertaken to redesign, recommission services commissioned by Public Health. And we've had a look at 5 areas: health checks, and the what if sort of questions there are about targeting, and particularly sort of gender and deprivation levels. Smoking, Abraham's mentioned that the model already reflects a long-term trend in smoking incidence. We know that what we've done now is said, well, actually, there are new intervention models in terms of group work and the likes, rather targeted one-to-one. And there's now, of course, the government policy. So we needed to test those, and I'll show you briefly some of the early outputs. This is all work in progress at the moment. A number of areas in children and young people, reducing the experience, which has already been touched on, adverse childhood experiences, weight management and frailty. And if we go on through the slides, you'll see how the sort of systems within a system type methodology and the fact that we can build relatively simple models to explore the impact on the larger population cohort model is being used. The next slide. important to stress that this is not a darkened room analytical exercise purely. We've established a very simple sort of process. There's a service lead or public health lead in each of these areas, and we've had the conversation both in terms of describing the art of the possible using the cohort model, but then trying to distill the objectives that the service lead has in terms of potential transformation. We've then typically conceptualized a proposed transformation, and we've done that outside of the cohort model. And we've built, again, some very relatively simple 2-3 stock models, depending on the conceptualization. We've then moved into data gathering, testing the model outputs, and then using that to inform the transformation program. And when we're presented with options, or transformation objectives, we've got 4 options in terms of what we're given in terms of the cohort model and what's possible. So we may find that the question is that the model is already amenable and we're simply extracting data using the interface, etc. And that's the case in 1 or 2 instances. It may be at level B, if you like, that additional output. So the model has the potential to answer the questions without significant rewiring, but we do need to connect a few things and create new model outputs at the interface layer. A number of the developments have been in the sort of minor model development, and I'll show you 1 or 2 of those in terms of embedding a module, if you like, within the larger model that impacts on a particular risk factor. And you'll see some of that. And we have been presented with in effect, models that are out of scope, either due to their complexity or often because they are, I suppose, tactical service redesign modeling, which the cohort model isn't designed to accommodate within the model itself. They'll have different timescales, different levels of detail, but they do present opportunities for other modeling work that may have the potential to inform some of the assumptions we make within the cohort model without changing the purpose of the cohort model itself. Next slide just introduces the NHS health checks. You'll probably be familiar with those, improving health outcomes, quality of life, etc., and certainly identifies people at early stages of different challenges and seeks to influence. So it is a service delivery option, but it impacts on risk factors. We then, the next slide, developed a simple flow to check our understanding. And this is the sort of level of detail that within the model, we experimented with this in terms of translating that simple flow into a stock flow. We arrayed it to reflect some of the targeting options that were being described to us in terms of gender and deprivation. And we started to explore what if we had an improved targeting rate or improved attendance, etc. So all of that was started to be impacted. The next slide, we developed 4 scenarios. The scenario A is always, let's compare it with what's happening now. So that's the baseline. And we went through at different options in terms of the gender option, in terms of scenario B, different levels of risk factor and the likes. Scenario C was built on that in terms of uptake, and scenario D, improved uptake from deprived and ethnic minority populations, increased treatment. So we conceptualized those as scenarios, and the next slide just gives some very high level learning. What was the impact? We developed some simple high level cost benefit from these interventions as part of the input to the transformation program. But always, I mean, we're now sort of reflecting on some of the scenarios. The lead consultant who helped us 6 months ago has now moved on, and somebody else is there. They have slightly different questions or different scenarios, but just demonstrates how we've enhanced the fundamentals, the underlying cohort model, to answer new questions as they emerge. The next couple of slides talk about smoking. So this is just the development of the interface stage. We've got the baseline reduction for societal change, but we wanted to explore what the government policy might what impact that would have. You saw our sort of aspirational 12%. Maybe in 5-10 years' time, that's now more achievable because of that policy. The evidence will start to emerge over the next few years. So we've just had to make hypothetical assumptions, if you like, in terms of the potential impact. And the sort of remodeling the Alan Carr, been told that's a sort of proprietary approach, but it's a sort of approaches like more group work rather than targeted one-to-one, demonstrated to be effective in certain cohorts and populations. So that's introduced within the model. And the next slide demonstrates how when you embed that in the existing model and run a particular scenario, it then has the consequential, not only in terms of smoking prevalence, that's the primary effect, but it also then, because it's embedded within the cohort model, informs the risk of long-term conditions. And here's an example, obviously an obvious one in terms of COPD. You've got a 25-year run there. You're introducing the change after, can't quite see whether it's at 8 years or whether there's a slight difference earlier on, but the model at the moment is based in 2018, so 8 years would be 2026. So we may well be thinking about how that introduces and how it gradually impacts over time. So that's the switch and the type of outputs. The next slide talks about embedding the switch off, and there's a very similar 2 or 3 stock model that has been embedded as a module within the wider cohort model to inform these outputs. The learning, one of the learnings from this is that some of the benefits of reducing adverse childhood experiences or trauma in early life won't become apparent for decades. They are so there's certain sort of transition benefits. So what we're looking at here is using the external evidence, if you like, to say this is of benefit in the short term to the experience of young people in terms of trauma and potentially things outside the model like education or offending rates or the likes. So we can inform that debate. It's not contained within the model, but if we can demonstrate the potential to reduce, that can be translated. The longer term benefits, we sort of take on trust, if you like, because they are beyond even the scope of this 20-25 year model. Weight management, here's an example, again, a conceptualization. We've got 5 categories. We've got services that are targeted. So there's an element here of service modeling, but what we're doing here is modeling and exploring the ability to have a more sort of flexible referral process into the different services. And in fact, even at the tier 1, 3 and 4 service level, the ability to refer between them rather than always going back up into the wider system. So it expands the model. Again, is a small module. The next slide just describes some of that in terms of how we're still recognizing the wider societal and behavioral factors. And we were able here to learn from specific obesity modeling work that had been done both in which area? One of the areas of Kent as well as Medway. So that was work that was done 2 or 3 years ago. So we simplified that model, we embedded it within the cohort model and start to generate new outputs. The last area that we've been asked to explore is frailty, mainly around posture, falls, risks, etc. We know that any interventions, any slowing of progression of frailty, whilst possible, will only moderate any increase in the demand for that. But we're starting to ask questions and extract outputs that you've seen earlier on in the presentation as well at a very high level. And the question there is about slowing progression through to the frailty cohort. Last 2 slides. Just in terms of the process, the health checks transformation program was the first of the 5 that we've described. and reflecting on that cohort model, a useful sobering tool, which basically means that there's no magic bullet in some of these things, but there is benefit that you can derive and scale. So rather than sort of running scared or thinking that this is the best thing since sliced bread and will solve all our problems, both those extremes are not true, but where are we in the middle? And we've done some modeling where, the theory was great that it would have a significant impact, but actually in the context of rising demand, it was only moderating. So there's that sort of sobering element in terms of what's actually happening within the population. Clearly stakeholder, sorry, just back the slide. Stakeholder engagement was critical, and that's if you're learning how to do system dynamics modeling, and several of you are, please do take the messages about that sort of, don't take it as a data modeling exercise, take it as a system modeling exercise, sharing of mental models, understanding what's really out there and what's being asked. So that stakeholder engagement is absolutely critical. Scenario assumptions are always interesting because we need to sort of qualify any what if statements with, well, are we saying what if because there's evidence and we want to apply it, or are we saying what if because we just like to find out what would happen and we then need to find out the evidence? So being honest about scenario assumptions and how realistic they are. Some of the examples we've given are totally unrealistic in terms of what they suggest could happen, but we're not actually suggesting they would happen. Removing all adverse childhood experiences trauma is not going to happen, but actually we've asked that question of the model to see what the full potential is, or the full contribution of adverse childhood experiences or trauma on the population, and we then just say how much of that can we chip away at. So scenario assumptions are critical. Local robust intelligence assumptions are needed. There's always that work, but don't wait until you've got the perfect data set. And the final slide. Supporting the transformation process. It's part of that process I mentioned at the start of embedding the capacity and skills. We've got one additional member from the WSP team, but there are 3 members within the public health intelligence team who are progressing this, and they do quite a bit of the grunt work, I suppose, in terms of gathering local intelligence, having conversations locally. We're providing the expert assistance and some of the initial conceptualization of the potential changes. The work is designed to assist those early stages of designing the desired transformation. And the cohort model is playing its part. But it demonstrates how this type of modeling is something you take with you on the journey, rather than that you do produce an answer and put it away for posterity. So, concluding comments, as Abraham said, the slide deck can be distributed, and hopefully that's been useful and informative to people at any stage of the journey in terms of the use of system dynamics in this type of area. Thanks, Rachel.
Thank you, Peter. Yeah, Rachel, over to you. We're happy to answer any questions if there's any time.
We've got a few minutes, and yeah, so thanks both for taking us on that journey. And thank you. I've received the email now, Abraham, so I can share with everybody the full slide deck. And what I'll do is I'll probably put that on the website, because my mailbox is too full, and people prefer a link to a big file. Or is that just me? So yes, thank you for telling us all about that. Your modelling. I'm just going to share my screen because there are 1 or 2 comments, and we have got time just to hopefully address a couple of them. Let's have a look. So if I take the liberty in sort of selecting them, so we're not confused as to where we're going on, because
there's one hand, Rachel. There's one hand up as well, just in case you want to.
Oh well, I'll definitely. I shall go to hands first. Who would like to
Nathan?
say something?
Nathan Thomas.
Hi, thanks. Yeah, I suppose my question, I'm a little bit unsure about what your overall aim is with this work. And I think it might just be things not joining up in my own head. But so you talked about deprivation quintiles. Obviously, you're never going to be able to move people in the lowest quintile up to the average, because if you're improving things for people in the lowest quintile, then obviously the average moves as well. So is the focus on improving absolute conditions for those in the bottom quintile, or is it about reducing the range of health outcomes across the population? So
there's a bit of both, and we were very aware that IMD is a relative index, and therefore yes, the average issue that is well rehearsed. So, and that's why we went back to the guts of IMD and sought to quantify and turn it into an absolute level. The cohort model initialization process reflects an IMD, but it's a static item. So we already factor in the fact that people in the lowest IMD have a factor difference in terms of risk of certain conditions. You can imagine the table, but that is that is static. It's once off at the start. It assumes that there's no change in the absolute level of so what we wanted to do, and this is the conceptualization, was reverse engineer it into the IMD, turn it into a dynamic and an absolute rather than a relative and a one-off. But it is work in progress, and I think what we've done is demonstrated that it's possible, but haven't fully embedded it.
Yeah. I think it's just me realizing for the first time that actually you could do an awful lot to improve the health outcomes of the people in the lowest quintile, and still not actually have any impact at all on health inequalities. Because if health
everybody
keep improving for everybody else as well,
yes, that's right. Yes,
then
right.
So
it becomes a bit of a philosophical conversation, which I thoroughly enjoy, but maybe we'll take offline.
Thanks, Nathan. So we got another hand up. I think it's Samuel.
Thank you. So I'm from an analyst background, but with a very, very light experience of modelling from COVID, unsurprisingly. And I guess the question I had was, obviously modelling relies, particularly complex modelling, relies on quite a lot of assumptions about interactions between interventions and outcomes, as you explained to begin with. And I guess obviously a lot of those assumptions are going to change as our knowledge changes about the impact of those interventions, or even if something changes, like if you've used mid-year population estimates for the last 10 years and the latest sensor shifts everything, as a really basic example. But presumably then you have to keep going back and reviewing those assumptions based on the kind of newest knowledge. And I guess, is that an ongoing process? How do you do that?
Absolutely.
It is. And then
and
the COVID example. Sorry, go on.
Slight follow-up question was also, given the complexity, when you're presenting this to decision makers, it's quite hard. It's harder for them to unpick and understand how you've got to where you've got to. So how important is kind of modular ability to translate that information? Because this feels like a bit of a leap of faith for decision makers, because they can't backwards engineer what you've described to them, if you see what I mean. So sorry, two questions there, but hopefully.
So the second one, fairly briefly, but the second one is sort of robust documentation, and we've upped the importance of that in terms of transferring the capability and understanding to the Kent team. So there's a full documentation and a sort of this is that type explanation, as well as a link back to any evidence or lack of evidence, or sort of quality of evidence, if you like, in terms of what's being described. But in terms of the new evidence emerging, COVID was a really good, that was on speed. Okay, so we in the first 3 months, we probably met 2 or 3 times a week, as new evidence, as new policies came in, as we triangulated. The other key thing in terms of COVID experience was that we were constantly calibrating the model, or at least comparing the model outputs with the actual. Now, we weren't modeling actuals. We created a model to reflect the system, but when the actuals departed from the models, we then reflected on why that was, what assumptions we need to change, and therefore what we learned about how the system behaved. And that gave confidence in terms of, is this a 1 week projection? Is it a three week? Is it a 3 month? And the further out you went, the more you knew might change. And the rapidity of that learning cycle slowed a little, but it then had to pick up again in the autumn of 2020, for example, when we suddenly realised something was going on in Kent, and it wasn't because everybody in Kent was naughty and mixing more. There was a new, and we actually we suggested the presence of a new strain of COVID before anything came out officially nationally, because we couldn't see another explanation for the growth in cases in Kent compared to what we were modelling. So we put a new COVID strain into the model before it was official, and then we asked the question, what is its severity, what is its hit rate, etc., as the evidence came out. And that was on speed. In the cohort model, it's a slower, more leisurely process, but the process is still the same. There was a question, Sarah, I noticed in terms of transferability there. The model can be calibrated to other areas. There are, and we've gathered a set of, I suppose, demographic data particularly, and also sort of relative incidence data and the likes, that enables us to do a first cut that then needs to be validated and triangulated with local data, particularly in respect of access rates to services, which is where Abraham's earlier comment comes in terms of the importance, the value of a linked data set. And also the alignment that we've worked hard on in terms of segmentation, that the model actually reflects at a meso high level the broad segmentation of any population health type approaches.
Okay, thanks very much. So we are running close to time, and we do have lots of comments, 1 or 2 questions. So what I'll do is, if it's okay with both of you, if I could share them with you after the session today, and if you would be so kind as to respond to them. The only one, and then I'll share them with the wider network as well, so not just those people who are there today. That'd be really helpful. You could do that. But just looking at the comments, I've just seen that Stacey has. This is massive favoritism, so my lovely colleague Stacey, totally biased. So Stacey and Sally Thompson lead up the health and care simulation community of practice, in fact, which you may have
we're aware of and contribute to.
And I'll just pop the link in here.
Happy to do that, and we'll await the email from Stacey. And the Health in 2040, I haven't done a detailed analysis, but broadly, yes. And I think we are. I mean, we could have written part of Chris Whitty's annual public health report last year. It wouldn't have been a sort of a match precisely, but the things that he was talking about and that Health Foundation are talking about. But of course, both are high level patterns, and we found this in COVID, that actually applying it in a local area is critical. So you've got a national picture there from the Health Foundation, Chris Whitty, and in some of the national modelling that was done during COVID, but the real value was, what does it mean for us in Kent or wherever?
Yeah, the implications thereof. Okay, well, we have just tipped over, so I would like to thank you ever so much again for coming here today and spending some time with us. Lots of interest, lots of people saying how much they've enjoyed the presentation today, and I will I've just popped up a slide on the up and coming huddles, but I would just like to say thank you again, Abraham and Peter. I'll be in touch, and thank you everybody else for coming along today, and I'll see you all in a couple of weeks.
Great.
Okay.
Thank you.